Okay, so when we're talking about fiber, it is non-digestible. It is a carbohydrate component of plant foods. Examples: fruits, vegetables, legumes, whole grain breads and cereals, nuts and seeds. Fiber can be consumed from food, can be taken as a supplement. There's powder you can mix in with water, and then just drink it. It's like a xylem and like a methyl cellulose derivative. It has a lot of benefits, right? So it lowers blood glucose levels, it lowers cholesterol levels, it lowers blood pressure, it increases your ability to feel full. It improves, laxation. It feeds the gut and our bacteria. It increases production of, certain types of fermentation that happen in your gut to help basically feed the good bacteria. Let's see what else I can tell you about this. This particularly is really important when we're talking about constipation or IBS. So most people who have IBS are told that you need to increase your fiber, because if you don't, it can make the symptoms worse. When you're going through IBS and you don't have enough fiber, and you have issues with constipation and abdominal pain, it is going to create more pain related to that versus if you eat fiber while having IBS, it relieves the symptoms. So basically, the education on this is going to increase your snacks and fruits. So like raspberries, kiwi fruit, mandarin, strawberries, passion fruit, oranges, things of that nature. Include vegetables with meals. Broccoli is a good one. Carrots, green beans, potatoes, skin on, corn, eggplant, things of that nature. It says you don't want foods in high fat like potatoes, but potatoes can kind of go either way. So hopefully potatoes isn't going to be an option, because technically it is on the okay to eat menu, but I know that you guys have it listed otherwise. The most important, wheat bran is not recommended with IBS. All right. So when you're increasing your fiber intake, you need to do it gradually so that your bowels have time to adjust, and that's only in IBS. So that should be everything that's going to be relatable to healthy choices. We've already talked about what works. Plenty of water intake. They usually say a liter to 1,500 milliliters. No stimulant laxatives. Most important, no stimulant laxatives. And they will increase rebound constipation. So that should be it for this one. All right, so when we're dealing with compartment syndrome, this is one of those super important deals that kind of goes a little bit past all of our little notes that we have here, but it's a good start. So basically, compartment syndrome is a condition in which swelling causes like an increase in pressure within a limited space within the muscle compartment. So because the fascia surrounding the muscle has limited ability to stretch, continued swelling can cause pressure that comprises of like function of blood vessels, nerves in the compartment. Capillary perfusion is going to be reduced below what is needed for tissue life. So it's going to start breaking apart tissue. And compartment syndrome often involves the leg, but it can occur in other muscle groups. So there's like 38 to 40 different compartments in the upper and lower extremities. Two reasons that we have it. Decreased compartment size is number one. So there's just too much swelling going on in the area to fit the area that it has to take a cascade of swelling. Two, there's increased compartment contents due to bleeding, inflammation, edema, IV infiltration, etc., etc. So edema can create enough pressure to obstruct circulation and cause an occlusion from the venous system, which will then further increase the edema that you're going to have, right? When arterial flow becomes compromised, you have tissue ischemia, and then the tissue dies. Remember, arterial blood flow is important to the entire body part itself, whereas the venous system is important and making sure that we have good perfusion, but it's kind of the backup system, if you will. So the bigger deal is if we get into the arterioles, because at that point, when the artery is occluded, we have just nothing but necrosis and ischemia, right? So the tissue eventually replaces the healthy tissue, and you get this fibrotic or fibritic tissue. So let's see, disability happens, contractures happen, loss of function happens if it keeps going on. If you delay things, it's going to lead to irreversible muscle and nerve ischemia or worse. You could sometimes have to have amputation as a result of this. So what does it look like? So compartment syndrome, basically it can occur within 4 to 8 hours after the onset of the compartment syndrome. And what can occur is the tissue ischemia itself. Another way we know is one or more of the 6 Ps, like pain out of proportion to the injury, increase in pressure in the compartment, paresthesia, which is like the numbness or tingling, or the boom, 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 the thumping that goes, paralysis or loss of function. Pulselessness is also a big issue because remember, we're compressing the area from the internal structures into the external structures. So if it looks bad on the outside, it's a big old fat mess on the inside, right? So most important is prompt diagnosis. And what happens if we don't get this taken care of? Well, again, that area basically can die. So what is the most immediate intervention? That's surgical decompression, aka a fasciotomy. Usually it's done at the bedside, although if it has time to go into the OR, it will go into the OR. Usually if you have a compression injury from mechanical equipment, or a motor vehicle accident that compresses the area, et cetera, we don't have a whole heck of a lot of time to fix that problem, so we just go ahead and slice and dice while we're at bedside on the trauma unit, because they have like a trauma bay area where you could do pseudo surgical procedures. So we usually go to the trauma surgical procedure room and do it there. Sometimes I've actually had to do it at the bedside because there just wasn't enough time. And we usually give them like fentanyl to calm them down and knock them out and at least make it doable, if you will. So those are the big spots on compartment syndrome. I think we can move on to the next slide. So ice massage and pain relief measures. Ice application is like one of the most important first steps for treating acute injuries like strains, contusions, tendon ruptures, overuse injuries, things of that nature. This is going off of a component of the RICE therapy, RICE, which is rest, ice application, compression, and then elevation. We do it a lot in boxing. If you get cracked in the face really well, you'll notice they have a silver piece that the coach is going to then wait until the boxer gets into the corner of the ring, and he'll push down as hard as he can onto that area, and it is actually dunked into and submerged in ice, and it's a metal contraption, so that when it hits that area of the cheekbone and the eye, it reduces that swelling nearly immediately. So that's the point of it. It reduces pain, sensation, blood flow, and then you have like a gentle rotation of movement that will help mobilize the soft tissue and give a regular massage and give relief. Because you got to remember, inflammation, it's the body's natural response to injury. So in the face of, a sprain or a tear or anything that is going to have an immune cell mediated reaction, the best way to deal with that inflammatory mediator is just to strike it down with ice and just freeze it in motion, basically. Icing an injury, remember, has an opposite effect. It causes rapid shrinking of blood vessels and numbing the nerve endings that send pain signals to the brain. So that's how you get the relief from that. And I think that that's all you really need to know about that. It looks like all your bullet points should be good to go from there. And I don't really think you need to know how to physically do an ice massage. But just remember that its purpose is to reduce the blood flow in that area by way of shrinking everything down. And that's how we deal with this injury versus traditional inflammatory issues. All right, so when we talk about skeletal traction, it's used to align injured bones and joints, or to treat contractures or congenital hip dysplasia. It provides a long-term pull that keeps the injured bones and joints aligned. So to apply skeletal contraction, the healthcare provider inserts a pin or a wire into the bone, and then the weights are attached to align and immobilize the injured body part. Now, I know it says should be more than 10 pounds, but honestly, fracture alignment and balanced suspension traction, when we're talking about things of that nature, the weight for skeletal traction is going to range from 5 to 45 pounds. The use of too much weight, obviously, it can result in the delayed union of the bones. And the major complications are usually infection of the pin or insertion site, and potential for prolonged immobility. So the balanced suspension traction is the most common type. Fracture alignment depends on correct positioning and alignment of the patient. While traction forces need to stay constant. So for extremity traction to be effective, forces need to be pulling in the opposite direction, or what they call counter traction. Counter traction, it's supplied by the patient's body weight or by weights pulling on the opposite direction. You should have a picture if you go into your med-surg book. Should be on page 1453 that shows you what actual skeletal traction looks like. Couple of important points of contingency. You should never mess with skeletal traction or the counterweights, ever, never, never. Those have to be changed by a healthcare provider or a physician. Like, that order's got to be changed to move it, to touch it, to anything it, okay? So the usual question that we get regarding skeletal traction is going to be a question based on, are you going to move the traction? Are you going to relieve the traction to do a procedure, things of that nature? And the answer is, I ain't touching nothing. So that's skeletal traction in a nutshell. All right, so when we're talking about skin traction, it's traction devices. They apply a pulling force on a fractured extremity to attain realignment, while counter traction pulls in the opposite direction. So the most common types of traction are skin traction and skeletal traction. And I just talked about skeletal traction in the last slide. So when we're talking about skin traction, it's generally used for short-term treatment, like 48 to 72 hours, until skeletal traction or surgery is possible. And the reason that we don't intervene with surgery, because I had an orthopedic surgeon, and I asked him, hey, why are we waiting a day to do this? And he goes, and I like, no joke, I'll never forget this, and neither will you. He looked at me very calmly, because he was a very sweet guy, and his name was Sergio, and he goes, hey, listen, have you ever gotten hamburger meat that was in one of those squishy, like, sausage containers, and then you stabbed it? And I said, yeah. He goes, what happened? And I said, well, because it's so tight, then the hamburger meat comes out of it. And he goes, yeah, that's why we wait for the inflammation to settle itself down, and that's why we do these types of bucks traction and skin traction, so that when I slice them open, it doesn't come slicing out and spewing out at me. He said, you only make that mistake once. And I was like, oh boy. So that's why we actually do that, just in case you're wondering. So we use tape, boots, splints. They're applied directly to the skin. It basically helps decrease muscle spasms in the injured extremity. Traction weights for this type of traction are usually 5 to 10 pounds, and bucks traction is a type of traction for the skin that is sometimes used for a patient with like a hip or a knee or a femur fracture. Pelvic or cervical skin traction, it could require heavier weights applied intermittently, and that would make sense because it's a heavier piece, right? So if it's a heavier piece of your trunk, you're going to have more weights. So in skin traction, regular assessment of the skin is a priority, because the pressure points in skin breakdown can develop very quickly. And then you have to assess the key points every 2 to 4 hours. And of course, check your 5 Ps for neurovascular issues that are related to the same thing that we just talked about earlier when we're talking about tissue ischemia, and we're talking about venous ischemia versus arterial ischemia, and compression. Now, when we're talking about adolescence and sleep, hormonal changes are going to contribute to this. Obviously, depression might contribute to this as well. We also might have conditions like narcolepsy, sleep apnea. People with diabetes usually fall under the sleep apnea regime as well. Some of the time they can go into full narcolepsy. There's medications for things like narcolepsy, usually is in the form of a stimulant to keep them awake. But when we're dealing with the average person who's adolescent and has trouble sleeping, be it from insomnia, be it from just poor sleep hygiene, we're going to want to teach them cognitive behavioral therapy, or CBT. It is basically stress management, relaxation breathing, using guided imagery or strategies. And why wouldn't we use something more aggressive? Well, because they're teenagers. Their frontal lobe isn't fully developed until they're 25, which means their personality traits haven't fully become full circle in its development itself, right? So we don't want to do anything that's going to mess with their ability to fully function as an adult as they get older. So the method with these guys is going to be, the worst case scenario is going to be medication management, but we want to start low and go slow with them. So we're going to have them do cognitive behavioral therapy or sleep hygiene techniques, which are things like don't go to bed unless you're sleepy. Take the TV out of your bedroom. If you're not asleep after 20 minutes, get out of bed. Do a non-stimulating activity. Return to bed when you're sleepy type of a deal. Let's see. Adopt regular pattern for when you go to bed and when you're awake, right? Begin rituals like a bath, a snack, what you can do to relax before you go to bed so that you're training your brain that it's time to settle down, right? Get a full night's sleep on a regular basis. Make your bedroom quiet and dark. Don't read, write, eat, watch TV, talk on the phone, use technologies while in bed because that's going to keep you stimulated. Obviously, stay away from caffeine, nicotine, alcohol, things of that nature. Don't go to bed hungry because then you'll get up in the middle of the night wanting to eat something. Avoid sleeping pills or use them cautiously. Benadryl isn't the answer for everything, guys. Practice relaxation techniques, avoid strenuous exercises within 6 hours of your bedtime. Things of that nature would be considered cognitive behavioral therapy treatment. And then obviously, of course, the rest of the things you have listed on your slide are completely adequate. All right, so when we're talking about propranolol, it is a non-cardioselective blocker, and what that means is it blocks the beta-1 and beta-2 adrenergic receptors. It reduces blood pressure by blocking the beta-1 and beta-2 effects. Now, it's the same as cardioselective blockers. However, it could cause bronchospasm, especially in patients with a history of asthma. So those are the big no-nos that you're going to deal with them. So what does it do? It slows down your heart rate. It makes it easier for you to pump blood around the body. It's usually for high blood pressure or for other heart problems, but it can also help with physical signs of anxiety like sweating and shaking. So yeah, it looks like you have all of those things listed as well. And we talked about contraindications of asthma. Why is it going to be a problem with Raynaud's? Well, because it's a non-selective, the problem that you have with Raynaud's is you have chilly fingers, and that is related to vasoconstriction, which is what this is basically going to also contribute with, as well as, don't forget, the bronchoconstriction as well. So that's all I've got for this medication. I think we can move on, just so long as you understand what usually comes up in these exam questions related to propranolol is going to be the fact that it is a bronchoconstrictor and you can't have a history of asthma. All right, so when we're dealing with Xanax, we are dealing with anti-anxiety agents. They're known for causing dizziness, for causing lightheadedness, drowsiness, unsteadiness. They may decrease the patient's ability to think or react clearly and quickly. They should not drive. Don't get on any hazardous machinery. You shouldn't be performing activities that require alertness until the response to the drug has been determined and you are okay to move about the world with that in your system. Symptoms often disappear after the patient has been taking the medication for several weeks. Patients should change sitting or standing positions slowly to minimize orthostasis. Let's see, our peak action in 1 to 2 hours. It has a half-life of 12 to 15 hours. Make sure that we're trying not to give it to children under the age of 18. Further, we need to be very careful when we give Ativan to the elderly because they hang on to it longer. Because remember, things in their liver and kidneys are going to be a little bit slower to move about, plus peristalsis is slower, so they're going to hold on to that medication for far longer, so you got to be careful with that. Patients need to be told that they need to notify the nurse if they have new trouble or they have ulcers, sores in the mouth, hallucinations, feeling confused, skin rash, jaundice, bradycardia, difficulty breathing, sore throat, things of that nature. Got to keep the medication out of the way of kids, obviously. Let's see, you should not be drinking alcohol while taking the medication. That's an obvious one. Cigarette smoking, the use of caffeinated beverages like tea or coffee or cola, it's going to decrease the effectiveness of the anti-anxiety agents. Because what does nicotine do? Well, it supposedly relieves you, but it doesn't. It vasoconstricts you, which causes you to be a little scatterbrained. Benzos, they're not intended for use of pregnant women, period. If the patient is pregnant or breastfeeding, or they could become pregnant while taking the medication, you need to notify the healthcare provider immediately because this is a no-no. Respiratory depression is obviously a huge risk. And your contraindications look really good, so I think that that's all I've got to talk about when dealing with Xanax, and I think we will be moving on to Ativan, which isn't going to be much of a difference, so let's go ahead and knock that one out next. So I like what you have on this slide for Ativan. So these are used for alcohol withdrawal, yep, for seizures, yep, see that too, status epilepticus, good, anxiety disorders, perfect, no myasthenia gravis, that's perfect. So here's what I'm going to tell you. The action peaks in like 2.5 hours, has a half-life of like 10 to 15 hours. They can experience withdrawal that is manifested as insomnia for 2 to 3 nights after cessation of the therapy or after you no longer have it anymore. We can use the IM injection as a para-anesthesic agent for like MRIs. Also, we need to watch out for giving too much IV sedation because, again, we can respiratory depress these guys really easy, especially if they're older and we're trying to get them into an MRI and maybe they're confused and elderly. That is a recipe for danger. You never want to give those guys a full 2 milligrams. I don't care how long it takes for them to finally chill out. Don't go in excess of don't even hit 2 milligrams if they're, in their 80s or 90s and they're pretty frail and fragile. That will never go well. We need to make sure that we try to reduce the dosage in the older adult, especially if they're debilitated. So that's all I've got to add on for Ativan. All right, so alendronate sodium is used to prevent and treat osteoporosis or thinning of the bone in women after menopause. The medication is also used to increase bone mass in men who have osteoporosis and in men and women to prevent and treat osteoporosis caused by long-term use of corticosteroids. It could also treat Peugeot's disease of the bone if that's a thing at the time. So medication, it's going to cause some unwanted side effects, but so does every other medication in the world. Basically, stomach pain's pretty common, difficulty with swallowing, heartburn, irritation or pain of the esophagus, muscle pain, in rare occasions, skin rashes. Blistering, peeling, or loosening of the skin is a big deal. Bloating or swelling of the face, arms, huge deal. Chest pain, chills, confusion, convulsions, cough, diarrhea. This medication can do some really, really nasty stuff. Again, patients should not sit up for at least 30 minutes after administration because that's a good point of contingency. You need to make sure that you're getting enough calcium and vitamin D as well. And you need to know the difference between the common side effect, which we talked about, or the severe side effects that would require medical attention immediately. All right, so when we're talking about levothyroxine, there's kind of a lot of things going on. First off, you need to be cognizant if your patient has like diabetes, cardiovascular disease, adrenocortical insufficiency, or pregnancy, because those are precautions to use thyroid supplements. So you need to make sure that we also don't have younger women who are just trying to take it so that they can lose weight, because that's a common finding that we have for women who want to do rapid weight loss is they will take the levothyroxine, and that will put them in that state, because it is a synthetic preparation. It is meant to increase in dosage in like 2-week intervals. Specific to patients who are older than 50, they're very sensitive to the thyroid hormones, so they have to begin in a very small dose, sometimes like 25% of what their actual dose is supposed to be. Usual dosage in the treatment of hyperthyroidism is 0.5 to 2 grams as a single daily dose before breakfast. Again, T4 is the treatment of choice for hyperthyroidism because of its purity and long duration of action. Therapeutic effects may not start for 3 to 4 weeks. Remember that, so that you have to do low and slow. Most patients begin feeling better within 2 weeks, and therapeutic results are usually often found in about 3 months. So yeah, patients should take the medication exactly as directed. Medication should be taken same time every day, preferably before breakfast. If it's too late in the day, patients don't need to take that medication because they're going to have difficulty sleeping. Response time is not immediate, usually improvements in 2 weeks. Take in the medication regularly, as ordered, same time of the day. 30 minutes prior to breakfast is most important. Changes in blood sugar and acetone will also need to be regularly tested, because this is going to throw those levels off as well. If you are getting anticoagulant therapy, bleeding or excessive bruising should be reported. Let's see. Any type of other medications you start, you need to let your healthcare provider know. And because it's commonly abused by individuals seeking weight loss, it shouldn't be shared with anyone else and should be kept locked in a secure place. Kids who can ingest large amounts of it can have severe reactions to it, and that's really all you need to know when we're talking specifically about levothyroxine. And yeah, that should be good enough for this, and then we'll move on to the next medication. All right, so digoxin, there's a couple of things that you need to pay attention to when we're talking about digoxin. So it's primarily to treat heart failure, but it also plays a role in treating fast dysrhythmias such as AFib, tachycardia, paroxysmal supraventricular tachycardia, things of that nature. All right, so when you're dealing with this, it's going to slow the heart rate by slowing how fast the SA node fires and slowly produces conduction through the AV node, okay? It also strengthens the contraction of the heart. Toxic levels of this medication can cause dysrhythmias very easily. Now, when we're talking about potassium levels, let me explain. So digoxin doesn't necessarily deplete the potassium. People with heart failure who take dig are commonly given diuretics, which is going to lower the potassium level, right? Because it is a traditional loop diuretic, not a potassium sparing diuretic when we have these types of arrhythmias usually. So when you have potassium loss, that increases the level of toxicity that your digitalis is going to create. So it's not that the potassium level is depleted because the dig, it's the dig concomitant with the use of loop diuretics in order to treat the condition that will also increase the toxicity level of this medication. So please understand that. And everything else that you have listed here looks really good. So I'm going to keep everything there as is, and I'm not going to add anything to that because this is a really beautiful slide. But I did want to go ahead and create that little bit of a window so that you understood what it is that it actually does, and the link to the potassium situation, and why that's so important. So Tegretol, which is what this is called, is an anticonvulsant. It's used for grand mal seizures. It's used for trigeminal neuralgia, things of that nature. Most importantly, honestly, this slide looks really good. So you have to monitor liver labs because liver toxicity is a thing. This medication can cause a severe allergic reaction called Stevens-Johnson syndrome, which is a nasty rash that literally peels you layer by layer by layer by layer. And it can easily be fatal, so you have to watch out for that. You'll see massive like peeling of the skin. So here's what I want you to picture. I want you to picture being back in kindergarten, using the Elmer's glue and like wiping your hands with it and then wafting it to dry and then peeling it away. That's what Stevens-Johnson syndrome looks like, only it's peeling flesh layer by layer like that, and all of your skin comes off with it. It does it on the face, the chest, it's everywhere, and it gets pretty gnarly. So if you feel like you were tough, then I would encourage you to give it a Google, and you will probably look at it for 10 seconds and be out of that browser search, because it's pretty nasty looking, I'm not gonna lie. Can cause low blood counts, that is accurate. Risk of serotonin syndrome, also accurate. You have to watch out for taking ginkgo biloba when you are taking this medication because of the serotonin syndrome. Also Wellbutrin. A lot of people who take mood stabilizers or anticonvulsants also take medication for depression, right? Because these things are pretty daunting. And when we have things like bipolar and epilepsy, trigeminal neuralgia, things of that nature, it can be very depressing to have those. So you can't have things like Tegretol with Wellbutrin mixed with some ginkgo biloba to help you with your nerves and your memory, because that will cause serotonin syndrome, which is a whole nother swarm of bees in itself. So I think everything looks good on this slide. I'm going to move on to the next medication, which should be oxybutylin. All right, so for oxybutylin, it's used to relieve symptoms associated with detrusure, instability, hyperreflexia, involuntary bladder contractions. It causes dry mouth, blurred vision, constipation, may aggravate symptoms of heart disease, MI, hyperthyroidism, GI problems. It also could increase the digoxin serum concentration, so you have to watch out for that. May increase the action of Haldol, enhance development of tardive dyskinesia, which is the repetitive involuntary muscle movements. You can't get around alcohol because it is innervated through the liver, so you got to stay away from alcohol. You got to monitor your levels as well. You have to give a lot of teaching to your patients so that they understand that this is a sensitive medication. You have to do a bladder diary documenting all voiding activity because of its severity as well. But I think everything else looks good that you have on this slide, so we'll move to the next one. So in reference to hydrochlorothiazide, I like all of your contingency points that you have here. A couple of things. Hydrochlorothiazide starts to work within 2 hours, and its peak effect occurs within like 4 hours. So that would be something that I would add. Your blood pressure lowering effects of hydrochlorothiazide may last 6 to 12 hours, just kind of depending, which is why they usually do a BID dose as well. Let's see. Stay away from alcohol, narcotic pain relievers, or sleeping pills. It may cause you to feel more lightheaded, dizzy, or faint when you use the medication. Most common side effects is that your blood pressure goes down, you get dizziness or headache, or you get orthostasis. All right, so Captopril is, I like all of these points that you have here, but additionally, I'd like to add when you're dealing with ACE inhibitors, they can commonly cause the non-productive cough in about 10 to 20% of people. It's an annoying side effect, and the only thing that will stop the side effect is discontinuing the medication. Specific to captopril as well is known as the first pass effect, where you take the initial medication and it will say, in administering a newly initiated order of captopril, right? And this will let you know to keep in mind and to keep in your head that orthostasis is going to be one of the commonalities of this medication, because this works through a way of vasodilation as opposed to other modalities where we're going to get that reduce in blood pressure or that reduction in blood pressure. So make sure that you understand that this medication, if newly administered, can cause some heavy rebound orthostasis with taking the first dose. Or it could really lower that blood pressure significantly. So you're going to have to make sure that you double check that blood pressure within 2 hours of giving the medication to make sure that we don't have any of those issues. All right, so with morphine, a couple of things that you need to add on to this slide. This is going to be used as part of your MONA protocol when you have a MI or suspicion for an MI. This is a Schedule II drug, primarily an opioid analgesic used for relief of severe pain. It's also the opioid analgesic against which all others are compared, basically. Produces sedation, euphoria when pain's present. It's used for preoperative sedation or postoperative analgesia. It's also used to get a better tidal volume and a better breath with someone who is trying to have that rapid breathing pattern when they are a hospice patient and they are actively dying. We use the morphine to give them a more level breath with good tidal volume so that they can be as comfortable as possible. Morphine is more effective against dull continuous pain than sharp spasmodic pain. IV meds should be given slowly over a 4 to 5 minute period, and you have to protect this medication from light and from freezing. Everything else that you have, though, I really, really like. So keep all of the other contingency points you have and add mine, and let's go to the next slide. All right, I like all of these points that you have. Watch for rhabdomyolysis is a big deal. These guys will complain of not wanting to take this medication at all because it's going to cause massive cramps. And a lot of times that is, again, this start of what they believe is a potential for rhabdomyolysis. Like I said, most people will just knock away from it and say, yep, not going to do it. And then we would try to give them a derivative. So let's see. Please understand that the usage of fibric acid derivatives like fibrates, like gimfibrazole or fenofibrate and statins together can increase the risk of rhabdo, which is, when you break down the skeletal muscle, which leads to renal failure. That's a common question that you'll see. Also, you will know that statins inhibit the HMG-CoA reductase, which in turn hinders cholesterol synthesis in the liver. You also need to know, they'll ask you a question like, hey, a person's taking simvastatin. How would you know that this demonstrates that the medication is given therapeutic effects? And then it's going to give you like your LDL, your HDL, and then you're going to have to look and see which one of those numbers is appropriate and therapeutic, and that would be, the topic of your answer. And let's see what other direction we might go into. You'll have increased creatine kinase levels. Statins have a high risk of causing statin-induced rhabdo. So again, it's the same breakdown. So if a patient reports muscle soreness or weakness while taking a statin, then the CK levels need to be measured. The creatinine kinase needs to be measured immediately, and that's the caveat with simvastatin. All right, phenytoin is one of those hardcore medications you got to be really careful about. It's for the management and treatment of epilepsy, generalized tonic-clonic seizures, partial seizures, status epilepticus, things of that nature. Causes headache, nausea, vomiting, constipation, dizziness, the feeling of you spinning, not the room spinning, drowsiness, trouble sleeping, nervousness, things of that nature. It will also potentially increase the risk of you developing osteopenia, osteoporosis, osteomalacia, or problems with your lymph nodes, including Hodgkin's disease. You got to be really careful about what you take with this medication. You can't have any clonazepam, no phenobarbital, no sodium valproic or valproic acid, no HIV medications. You can't be on hormone replacement therapy or take hormonal contraceptives, things of that nature. Need to avoid antacids and nutritional or enteral products because they decrease the absorption of the phenytoin. Those are going to be the biggest pieces of contingency points that you're going to run around when it comes to questions related to that. So make sure that you add those onto your notes. So IV piggyback, there's a lot we can talk about. We can talk about isotonic, hypertonic, hypotonic solutions. We can talk about IV piggyback and what's compatible and what's not compatible. So you wouldn't want to have a medication that is going to be a normal saline derivative as an IV piggyback if you have a colloid like a D5 with normal saline, or just a D5 in general. You wouldn't want to mix those together because obviously you'd have a colloid contaminant. Piggybacks can go into a lot of things. So yes, the secondary line is hung a little bit higher, but you also need to talk about clamping it once you're complete. We need to talk about back priming and what that means. Things of that nature is what's going to be covered under just the bullet point of IV piggyback, because I feel like that's kind of a broad term that can go in any fair direction at any given moment. So again, isotonic, hypertonic, hypotonic solutions, look those up. Make sure that you know which is which. Make sure that you know the direction it should be put in and how you cannot cross-mix that with your wrong primary set. Also, how long is the tubing good for? Usually the tubing is good for 24 hours. If we're going to be using one type of antibiotic, you have to have new secondary tubing for each introduction of a new antibiotic. You cannot use the same one. Yeah, I think that's pretty much going to cover IV piggybacks if I'm not mistaken. So physical restraints are equipment that physically prevents a person from moving freely, such as walking, standing, lying, transferring, sitting, things of that nature, whereas chemical restraints are used to restrict a patient's freedom of movement or to sedate the patient. The current standard is to exhaust every other resource you can before you have to put these restraints on people, because some of them can be very serious. When you're dealing with soft limb restraints, you have to have an independent order recirculating every 24 hours for this person, as well as justification that should be documented hourly. We also need to offer food and water and bathroom time, things of that nature, because if anyone has ever sat in one position for an hour, your body starts to hurt and break down. So this is actually pretty barbaric. I was working on a neuro ICU unit where people throw things and bang their head against the rails with a helmet on because they have a hemicranie. They have, shunts that they're trying to pull out of their head. They're throwing things because they're confused, et cetera, et cetera. And in my time, unless I had propofol on somebody and I had to physically restrain them so that I can chemically restrain them so that they could get better quicker, because we had to intubate them. I have never used actual restraints for the purposes of restraining someone that I felt was violent. And here's the difference. So most people are pretty restraint easy, so they'll throw restraint on a person just to keep them subdued. They're not animals, they're people. We can't treat them as such, so we have to talk to them. And then 9 times out of 10, if you talk to somebody and they're not 100% confused, you can work with a distance sit, or you can work with having a sitter in the room before you have to physically taper somebody to the bed. I mean, there should be only extreme cases where we'd have to do that. I've had to put violent restraints on people down in the ER because, you know, they're punching and kicking and trying to, you know, rearrange furniture, as I call it, which is where they just up and pick up furniture and haul it across the room. But other than that, you really shouldn't be restraining somebody with wrist or limb restraints, especially if they're confused and they're elderly. They can actually do more harm to themselves and break things if you put them on these restraints rather than if you would have just gotten a sitter. I understand a lot of times we don't have enough people to be there in that position to sit with them, but there's always something that can be worked out. And again, if you can absolutely avoid it under many costs, it can be avoided. Usually putting people in restraints is, in my opinion, a good excuse to, you know, get somebody chilled out for a very, very small period of time, but we could have probably done something a little more effective that would have been a better modality for them. And try to keep in mind, a lot of these people have a history of PTSD, right, for various reasons. And what are we going to do? Oh, yeah, that's right. We're going to put them at 4 points. That's a great idea. So, yeah, most of your questions related to restraints are going to be, how often do you have to chart? If it's violent, it's every 15 minutes. You have to have a renewal of the order depending on how many use of restraints. Usually it's every hour to 2 hours, depending on what that is. Usually it just stays at an hour. If it's soft restraints, it's every 24 hours. You have to chart on it every hour. You have to do circulation checks, things of that nature, versus a chemical restraint, which is like Haldol. And then you need to know what it was for. So if you have a severely confused individual who's trying to punch or kick at things, pulling lines isn't necessarily a reason to give a restraint, although it does help if you do have someone who is already belligerent and potentially harmful to themselves or to others. But again, unless you're like full on sedating somebody and intubating them, 9 times out of 10 you can get away with not using restraints. 9 times out of 10 people can be basic talked to, and we won't have to do so much rationalization for needing these restraints, and therefore we don't have to have 9,000 pages of paperwork that's unnecessary. We should never restrain a person who is alert and oriented unless they are being violent. And please make sure that you understand the differences in times when you should be getting a new order, when you should be renewing orders, of what type are considered violent versus non-violent, things of that nature. And that should get you past the slide about restraints. So I really like what you guys did with the slide. I would say that the only thing I would add to it is whenever you have a poor LDL and a poor HDL, you're definitely going to put this person on a statin. Whenever you've got triglycerides that are through the roof, statin is usually the first go-to. So that's a pretty common question on your NCLEX, on standard tests, on exit HESI, things of that nature. So in reference to cholesterol itself, that would be my only addition to this slide, and then we can move on to the next one. All right, so with peripheral vascular disease and ulcer and skin care versus arterial issues. So peripheral vascular, when we're talking about venous stasis ulcers, we're always going to put on our compression stockings. We're going to want to lose weight, elevate the feet, obviously, always. Stop smoking because it vasoconstricts. Cleanse the wound with a gentle area. Remember, when we have a venous stasis ulcer, the ulcer is from the inside out, because what we're doing is we're third spacing, basically a compartmental syndrome from the inside out, because all that fluid is pushing onto everything and it's softening the tissues, right? So this is not the arterial deal where you would not wear compression stockings. We want to wear those compression stockings even in the event of an ulceration, because we need for it to compress that fluid back up through the venous system, come up towards the heart like it's supposed to, remove itself from the area like in the ankle where the swelling is prominent, and that way we will be able to essentially quote unquote dry out that area, okay? So that's going to be different than arterial, where we don't want to cross our legs. If we have compression stockings, we better not wear those ever, never, 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 because when we start messing with the arterioles, we start messing with the true circulatory system. So if we occlude that area, we cause tissue ischemia and death. So we definitely don't want to do that if this is an arterial issue. Only peripheral vascular disease will we encourage elevating the feet, wearing compression stockings, etc., etc. So myasthenia crisis is a huge deal. Myasthenia scares me more than Guillain-Barré or Guillain-Barré, however you want to pronounce it, because this autoimmune condition basically starts from the top and goes down. So whenever this person starts to have exacerbative symptoms, I'm already getting ready to intubate them, right? IVIG is going to be what's going to help them. It usually takes about a series of 6 different IVIGs before they get better. And this is intravenous immunoglobulin, which is going to basically give my foreign body invaders and those fighters, it's going to bring those back into the area and tell them, hey, quit attacking self, because self is not the enemy. That's kind of how that works. Myasthenia is a really scary condition to have. And again, the main questions you're going to have regarding myasthenia is, does it happen from top to bottom or bottom to top? It's going to happen from top to bottom, which means the top of your body system is going to stop functioning first, versus with Guillain-Barré, you're going to start having weakness and deficits in your ability to walk, and then it slowly moves up past to your thighs, to your belly. It starts inhibiting peristalsis, and then it moves up to the top to where you have swallowing issues. With myasthenia, no, we go straight to crazy that fast. So these guys are likely walking in the door when they start having slight problems, and the next thing you do is we do an elective intubation.
So when you have too much anticholinergic medications or anticholinergic esterase, it causes excessive cholinesterase inhibition that can cause a cholinergic crisis. And what that means is you get really, really bad. So we have pupils that are less than 2 millimeters. We have a heart rate of less than 60 beats per minute. Systolic pressure is usually less than 80. You have decreased consciousness, like your Glasgow scale is less than 15. You have excessive sweating, excessive tears, poor air entry. There's just a ton of things that can happen to you because of the amount of, or the excessive amount of acetylcholine. You can have parasympathetic symptoms such as sweating, salivation, meiosis, bradycardia, diarrhea, circulatory and respiratory issues. So yeah, it can cause a lot of problems. And then when you have these issues, what do you need? Well, you need ventilation, basically. Oh boy, sorry. So yeah, you need intubation, and you need it quick, fast, and in a hurry. So I like all of these things that you have here. There's just a couple of little pieces and parts that I added on, but nothing's too serious. And yep, that's basically all I've got for the slides, so let's move on. All right, so acute gastritis. This is, I'm looking at your slide right now. It is the sudden inflammation or swelling in the lining of the stomach. It only directly affects the stomach, while gastroenteritis affects both the stomach and the intestines. The acute gastritis is just in the stomach. It looks like the most common causes of acute gastritis are NSAIDs and corticosteroids. But there are other things that can definitely cause it, like alcohol consumption, NSAIDs, we just talked about, H. pylori, stress, things of that nature. But the most common causes of acute gastritis, again, are NSAIDs and corticosteroids. It's pretty serious. I mean, it's serious for the patient because it's very painful. But as far as being serious, for long term, it's not actually very serious. It lasts about a few days to a few weeks. Once the inflammation's settled, the pain is gone. The problem with that is you can get recurrent acute gastritis. That can be long-term inflammation of the gastric mucosa, which is going to be chronic gastritis. So how do you fix it? Well, H2 blockers, so acid blockers helps out, or proton pump inhibitors. So Pepsid, Tagamet, things of that nature. And you have to be careful not to let it flare up. Again, you have to make sure that you stay off of those medications as much as you can, or quit drinking. Drinking large amounts of water, it controls the level of acid in the gastric juices. It helps accelerate the healing of gastritis. But you also have to watch out for drinking too much water before or after meals, because it can also be counterproductive. So gastritis is severe pain. I mean, it's burning, you vomit. That lining that gets inflamed is pretty nasty stuff. So you're very, very fragile. Green tea with raw honey is the recommendation to drink, but there are other recommendations as well. And they tell you the Pepto-Bismol is a good derivative to take, which is bismuth salicylate. And it can be used instead of a secondary antibiotic for this condition to kind of soothe things. But it's kind of, here or there. This is not as bad as GERD, but it feels worse than GERD, because GERD is a chronic condition, obviously. And it could also have some severe complications. So they tell you to stay away from spicy foods, high-fat foods, greasy foods, fried foods, very acidic foods, carbonation, alcohol, and chocolate. And then they basically want you to have bowel rest, to where you're not really eating or drinking much. Usually people with acute gastritis get put on an NPO status until it settles, kind of like pancreatitis. It's just fluids until it chills itself out. But yeah, at the very end it says it can lead to stomach ulcers. Sorry guys, stomach ulcers or bleeding, which requires urgent medical condition or medical attention. Yeah, that's accurate. It can lead to stomach ulcers or bleeding, and those do require urgent medical attention, but the likelihood of that happening is pretty rare, I'd say, because that pain is so intense. They usually come in to get that handled, and it usually does get handled before it gets to that limit, but it can get to that limit if you have a high pain tolerance. And I think that's all I have specifically for this slide, so keep all those other things in mind. And sorry for the yawning, I'm just waking up. So when we're talking about BUN and creatinine, we're talking about BUN as a separate entity, creatinine as a separate entity, and then you have your BUN and creatinine ratio. Please don't call it a bun, okay? We're not eating breakfast, right? We don't put butter on it, so it's not bun, it's blood, urea, nitrogen. So it's BUN and creatinine. They're both filtered in the kidneys and they're excreted in the urine. The two together are used to measure the overall kidney function. A BUN to creatinine ratio, it basically checks for problems such as dehydration that can cause abnormal BUN and creatinine levels. A low BUN and creatinine ratio suggests inadequate protein intake. It reduced urea synthesis, as in advanced liver disease. Also, sickle cell is another good example of this. A high BUN to creatinine ratio occurs with sudden acute kidney failure, which may be caused by severe dehydration or shock. A very high BUN to creatinine ratio may mean bleeding in the digestive tract or respiratory tract. So there's, again, they're mutually exclusive, but they're separate entities. So if your kidneys aren't working well, the urea nitrogen will stay in the blood. Normal blood contains 7 to 20 milligrams per deciliter of urea, and if your if your BUN is more than 20, your kidneys aren't working at full strength, basically. Okay. So creatinine is a big deal. Anything above 1.3 on your creatinine is considered high. However, creatinine can get up to, above 5. That's considered abnormally high and significant severe kidney disorder. I've seen creatinines into the 7s, the 8s. I've seen it up to 13 at one time if that person was, basically on dialysis and dying at that time. Here's the thing. BUN is a good predictor. Creatinine is a good predictor. The better predictor of the two, BUN's only going to let you know if you're dehydrated. It's going to suggest that you have some issues. The creatinine is going to tell you what your kidney function looks like, period, right? So if your creatinine is ridiculously high, like 2 or 3, I know that there's no way in Hades I'm going to give you even a drop of contrast, right? So the problem that we have with high creatinine levels is we don't want to give you any contrast. So that can mean a lot of things. That can mean I'm not going to give you a CT scan with contrast, which I might need contrast in order to do that. So what am I going to do? Well, I'm going to water down the kidneys, and we do that by giving you high amounts of fluids, which makes your kidneys move, which lowers your creatinine. So I might have to put you on simple fluids for a couple of days just to prepare for that exam. Now, remember, there are other things where we need that iodine or that contrast. And if I have poor kidneys, I can't use a lot of it. So can anyone think of something super important that would require you to have contrast? Well, if you have a heart attack and you have to have a catheter put in, or you have to have a heart cath, right? And you have to have some type of, stent put in. It's got to be put in with contrast because that's how they see it. They use the contrast while they're doing the x-ray, which is why they're carrying the lead on their body in order to be in the cath lab. That will let them know if it's in place. And if you have poor kidneys, there's no way in Hades they're going to do that because they're going to end up blowing your kidneys and then killing your heart at the same time. So the creatinine is a much larger predictor of, how poor those kidneys truly are versus a BUN, because a BUN can just mean, meh, they're dehydrated, whereas the creatinine being busted can mean your kidneys are shot, you're not allowed to do anything until we give you fluids and we get that creatinine down, and it might even be a temporary fix to a permanent solution, right? So there are people, again, we'll give them, 2 liters of fluid. We'll do it 50 an hour. We call those light fluids. And they may be sitting and waiting for days. So you have to take care of your kidneys, I guess, is the moral of the story here. But that's all I've got for BUN and creatinine, and I hope that helped you. If you need a little bit more information, just get your MedSurge book up. Go into the index, look up BUN, look up creatinine, look up BUN and creatinine ratio. There's a plethora of information, I assure you. All right, I'm going to teach you how I learned how to remember this because it's confusing. You're like, wait, I go cloudy to clear when I'm drawing, or when I'm pulling, or when I put air into it, I do cloudy to clear, but then I draw the insulin from clear to cloudy. Okay, blah, 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 blah. Here's how I remembered. It might help you. I hope it does. So my little rhyme that I gave myself was, if you draw air from cloudy to clear, your patient and you will never fear. If you draw from clear to cloudy, your patient will never dip down and get rowdy. Okay? If you remember that, I know that's the weirdest thing in the world, but to me, that's how I put it together, because trying to say, okay, I'm going to draw the air or put the air in from cloudy to clear, and then I'm going to draw the insulin from clear to cloudy. It gets confusing in there, but if you say putting air from cloudy to clear means you and your patient will never fear. If you draw the insulin from clear to cloudy, your patient won't dip down and won't get rowdy. For whatever reason, it works for me. I don't know if that helps. You might be able to find something that works better for you, but mixing insulin, that's the perfect order to do it in, and it makes sense, right? You want to put your air and your cloudy first, right? And then you want to put your air and your clear second, because at that point, we're lining ourselves up to then draw appropriately. If you draw clear first, you can tell how much clear you've drawn, and then from there you can tell how much you got on your cloudy, because there's literally a line of demarcation. Whereas if you do cloudy first and then you do your clear is going to bleed into your cloudy, and you're not going to be able to tell the difference. Does that make sense? Because there's a matter of viscosity that changes. So that's why you have to do it in that order, because you want to make sure that you're not putting too much in there. That's the whole shebang-a-bang reason behind it. All right, next slide. All right, I love this slide. I love everything you guys have for this slide, but you're missing some things. So what we're missing here is how to improve your A1C. All right, so all this other information is good. Remember, if your A1C sucks, just like insulin, if you're taking insulin and you exercise, that is going to lower your threshold, right? Because we're burning a lot of sugar off. So in the same principle, if you have a high hemoglobin A1C and you're not taking anything for your blood sugar issues, or maybe you are taking something, it doesn't matter. Exercise is going to help burn off that sugar. Eating right, obviously, taking your medications as prescribed, managing your stress, because remember, if we have a cortisol dump, that's also going to increase things. Sticking to your schedule, drinking alcohol in moderation, and then constantly checking your numbers or making those doctor's appointments are going to be super important. So yeah, all of these things are accurate. All of these things are very, very important, but also treatment is going to be diet modification, lifestyle changes, constant monitoring, and exercise. All right, I really like this slide, but we're missing one little piece here. So I'm going to pull up my little red dot. Hey, look, I got a laser pointer. All right, so influenza is a viral issue, right? So then how do we know? Well, we got this VIR, not the IR. VIR is literally virus. So if we are looking at any medication, they will all say VIR for virus. So you don't even need to know all this jazz right here, or all this jazz, or all that jazz. All you need to do is go, ooh, VIR. Yeah, that's my jam. Because they're going to give you several different medications to talk about influenza and viral respiratory infection treatments. And remember, influenza is a virus, so we're just looking for VIR, because virus goes with viral. All right, that's all I got for this one. Everything else looks really, really good. Yeah, so let's just move on. And I just wanted to throw that in there. VIR, not the IR. VIR. All right, cool. So let's talk about complications of immobility. All right, complications of immobility: muscle and bones weaken, causing loss of strength. Okay, so you lose 1 week, you atrophy 1 week for every day that you're in bed in the hospital. So your body starts to break down muscle as if you, in 1 day, have not moved for an entire week. That's some pretty heavy stuff. And that is a statistic that I've gotten from most occupational and physical therapists and orthopedic surgeons. It's also a statistic that I have confirmed. So it's a pretty serious deal, if I'm honest. So that's number one thing. Blood pressure or blood circulation slows, increasing the risk of blood clots. Well, yeah, sure. So if we have circulation that's not moving around, it's just kind of compressing in one area, well, what's that going to lead to? It's going to lead to death of that tissue, because it can't circulate, it can't breathe, it doesn't bathe itself in oxygen like it's supposed to in the blood. So it dies and becomes a pressure injury. That's how this stuff happens, right? Because we're not moving them. Lung congestion can occur due to reduced physical activity. Well, sure, if I'm laying flat and I have, phlegm bouncing up and down my carina and I'm laying, what's it going to do? It's just going to go into the posterior aspect and just accumulate and turn into pneumonia. That's how people get pneumonia in a hospital. Joint stiffness and contractures may develop. Yeah, I would say that they may develop, as in they're probably going to develop. And yeah, that limits mobility even further. Also, we get depression, and when we're depressed, we don't want to get out of bed, which furthers the complications. Check this out. Here's a fun statistic. So people who retire, sorry, I had to get a drink. People who retire make me nervous because people who retire sit on their lump and they're like, yeah, I'm going to celebrate retirement. I ain't going to do nothing but watch The Price is Right. And then after a week or two of doing that, they really can't get up and do anything. And then they become depressed. And then they don't really move around a lot. Now, there are a lot of people who retire and go straight to a volunteer project. I would encourage you to go ahead and take a mental note of that and do it. You ready for these alarming statistics? All right, cool. So if you retire at the age of 65, you have about a 76% chance of living 10 more years and about a 38% chance of living 20 more years. So, oh, it's because you're getting old, Molly. Okay, cool. So you have a 76% chance of living more or living 10 more years. Now, that's a pretty good chance, but a 76% is technically failing, okay, by our college's rules. So that being said, you have a chance of failing better than you have a chance of passing in life. What does that tell you? It tells you that being stagnant contributes to this, right? If your body is not constantly moving, then it's not going to go well for you, right? So I know a lot of people who volunteer, and these guys who volunteer are like 80, 90, 100 years old. Most people who are volunteer and are retirees, they live far, far longer than the average person who just retires and goes home. So take that into consideration. A lot of people are like, I'm not doing nothing when I retire. I'm sitting on my butt. Dude, I'm volunteering for every stupid little thing that ever existed in the whole wide world, man. I'm making flowers at the hospital. I don't even care because at least I'm getting up and I am promoting my health mentally, spiritually, physically. So keep this in mind when we're talking about complications of immobility, because this also includes people who decide to retire at the age of 65 and spend that time living their best life when you're 65. I feel like that's a little too late in the game, but you know, you can still have a very good existence after that. So make sure that you are setting yourself up with the intention of being able to maybe stop working so much so soon so that you can really enjoy life maybe in your 40s or your 50s, dare I say, because it's pretty freaking sweet. I'm just saying. All right, I've said enough about complications of immobility. I will move on to the next slide. All right, this whole slide is accurate. I don't know what else to say. So crutches, yep, fitted to allow 2 inches or 3 finger widths. It's 2 to 3 finger widths actually. Between the top of the crutch and the axilla, yes, because you don't want to put too much pressure on the axilla because you could do things like damage the area of the axilla, you can damage your muscle groups, you can pinch a nerve, etc., right? Canes. So I teach my students in health assessment about canes, and I always tell them, and I should not be able to say these things, I always tell them they need to be funny and keep their pimp hand strong, because their pimp hand that's strong is where the cane should be held, in the strong side. It's not cool, and I know I shouldn't say these things, but someone was really confused about it one day, and it was the first thing that came out of my brain because I had a brain blast, and then it just kind of stuck, and it was funny, and then people got 100% on that question, so I figured, okay, fine, I'm just going to keep it that way. So that's... The cane is held on the stronger side. I swear I should not be able to say these things out loud, but here we are. It's funny, it's comical, it's accurate. You'll never forget it now. So I would say sue me, but please don't, because I would appreciate not, right? I'd appreciate just a normal existence for once in my life. Let's just keep it there, okay? So crutches, canes, all appropriate, all accurate. I gave you a little quip to remember it, maybe a little bit easier. And hopefully I don't regret saying that for the rest of my life, but probably it's going to come back to haunt me, but probably not, because you guys are good people. So that's my hint that I have for that question. And now I'm going to move on. All of this about walkers is also appropriate. I wish I had something cool to tell you about this one, but I don't. I mean, they're pretty self-explanatory. I like the information you have here. And what you really need to know is the person more appropriate for a walker or a cane or crutches? That's usually where we see these types of mobility or accommodation questions. Okay, good. Hypertonic, hypotonic, isotonic. These are very important pieces. All right, so I don't know if you guys know this, but I want you to see the ratio and proportion, because some people are like, how do I know the difference between hypertonic, hypotonic, and isotonic? I'm like, cool. If you know your isotonic, then you know your hyper and hypo. And they're like, what are you talking about? And I'm like, cool, I'm glad you said that. All right, listen. I'm going to get my little laser pointer out because I'm super cool. All right, cool. 0.9. All I want you to do is look at numbers. You ready? 0.9. So 0.9 is our isotonic. That is our baseline level. All right. Notice how hypotonic is 0.45. Okay, guys, let's do a math game. I didn't learn math until I was 30, so if I know this, you should know this. You ready? 0.9 versus 0.45. Which number is bigger? Well, this one goes tenths and hundredths. This one goes tenths. This is the bigger number. This is the smaller number. Hypo, smaller. Hypo, smaller. Oh my God, Molly, that's crazy. No way. Yes, way. Okay. All right. Hypertonic, 3% saline, 5% dextrose, 10% dextrose. Which number is bigger? 0.9 or 3, 5, or 10? Oh my God, Molly, is it really that simple? Yes, honey, it is that simple. All right. If you get lost on your fluid and you don't know if it's hypertonic, hypotonic, or isotonic, know that your isotonics are 0.9. If it's lower than that, it's hypo. If it's higher than that, it's hyper. Period, point, and paragraph. Problem solved. All right, so restraints. Restraints, you have to have a physician order. You can't put anybody on restraints, period, without a physician order. You can get a verbal order, and that should be good enough for them, but he better be up in 15 minutes writing that order and putting it in place, because if you don't have it in place, by the time that security walks out of that room, because security is probably going to have to be called if you got to put someone in physical restraints 9 times out of 10, then you're in trouble. So make sure that you have that physician order. Make sure that physician comes up and watches that patient. Don't let them go slack and say, yeah, put your order in, you're fine. They need to have that order in. It is not a nursing order for you to put in, right? Because if legal stuff comes back and it shows that it was a verbal order, they have to be present within the hour to put in that physical order and change it from a nursing order to a doctor's order. Checking circulation every 30 minutes. Duh, right? You got to make sure that you're not going to kill any arms because you've had to restrain them. At the same time, there are some patients that will bite through the restraints. I'm not even playing. Yes, they're 90-pound little bitties that do it. But the ones that I'm more concerned with are the explosive alcoholics. There have been sometimes many a time you have to defend yourself when you're dealing with alcoholics or drug addicts that have had too much meth. I mean, there are some realities that we have to hit here. So make sure that you always have your back facing toward the door. Never have your back facing toward the patient. You're only ever going to do it once if you wake up from it. Because some of them will physically hit you. It is what it is. But there are things that you can do to reduce the amount of times that you're actually hit by people. One of them is standing your ground. One of them is talking with confidence and giving them the eye of, I wish you would. Because you'll learn in this world that a lot of people that say that they want to fight you are nothing but bumping their gums. And bumping their gums is when they're like, ba 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 ba, and they start pulling off their earrings like they're going to do something. But all they're going to do is just chest bump you and wait for somebody to grab so they can pull them off of you, right? Because they're really cowards. So the people that strike, and they strike hard, they don't tell you at all, right? They go from 0 to explosive with no words in between, right? Those are the guys you need to worry about. The person that's not saying a daggone word. The person that's running their mouth and trying to run up on you, that's some, silly schoolgirl, like, I'm going to meet you after class and we're going to throw the dozens at each other and then nothing ever happens but a bunch of people going, oh, right? So, like, that's not the patient you need to worry about. The patient you need to worry about is not being funny, haha, but the patient like me, right? I don't say much. I never complain much. But then when I get stupid explosive, I get quiet. That is when the fate of the world is resting on my thoughts, right? So, like, that is the type of person that you need to stay clear away from, because that's the person that's going to bounce on you and you're not even going to know what hit you, all right? They're going to do what I call rearranging the furniture, right? That's when they go throw in the chairs in the hospital. My dad did that a couple of times. So I'm just telling you, if you see a person with any type of history that has assault in it or has abuse in it or anything of that nature, don't corner those guys. When you do corner those guys, you're going to know real quick to stay away, okay? Again, 90% of the people who are going to try to fight you are going to just bump their gums, run their mouth. Security's going to get called, and the second they see those uniforms, they're like, oh man, they're just overreacting. Da, 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 da. Those are the guys I'm not so concerned about. It's the guys that don't say a daggone word. They're going to come up out of the bed, and it's going to hurt, and it's going to be very detrimental, right? And it's going to give you a little bit of PTSD, and you're going to get really nervous, but it's only going to happen once. Has it ever happened to me? I'm going to be honest with you, it hasn't. Have I seen it happen to other people? Absolutely. I've seen it more often than not. So there's always going to be one person on your unit who you know is going to be like the old school nurse that nobody wants to mess with. Find that person if it's intimidating to you until you get used to it. Find that nurse, call security. There's nothing wrong with you calling security while you put restraints on a person. I would encourage you to do it until you get used to it, all right? After a while, you'll find that you don't need security anymore, right? Unless it's super, super bad. Now, again, is everyone I put restraints on going to be super, super bad? No, because most of the restraints I put on people is because I'm giving them propofol, and I know that I have to intubate them, and people are going to jump around during that time. Even when someone has having an elective intubation, they're going to fight a little bit because that's just the natural propensity of a tube being stuck down your throat, even in an elective procedure. Demented people or people who have some type of mental cognitive impairment, they're going to be a little rowdy, but when you get their wrist, they're usually good. Be leery of them kicking, though, because you kick with better force than you punch. So stay away from feet. Never allow a pregnant person to put restraints on somebody. I've seen a pregnant person get kicked by a grown man who had dementia and who had delirium. And to get angry at a person that's like that, it's not going to happen. They don't even know what they're doing. So you got to be very protective of your family that you work with, right? Because your family is very much a work family. You got to think you're with these nurses more than you're with your own family some days, right? I got 12 hours with these people, and I go home and my kids are already asleep because it's already, 8, 9 o'clock by the time I get home. So you spend more time with these guys than you do your regular family, so treat them as such. Don't sit there and let them get kicked and punched and don't do anything. Don't go, oh, I'll call security for you while they're getting hammered. Back them up. Take care of them. As far as restraints are concerned, there's violent restraints, there's nonviolent restraints. Nonviolent restraints, you have to do circulation checks every 30 minutes. Violent restraints, it's every 15 minutes. You've got to do hourly rounds on these patients to make sure that they're okay, and you have to document that. You have to have a distance sit sometimes, who has to constantly document it as well. Every hospital has their different protocols, but the most important thing is you have to have a new order obtained every 24 hours when you're talking about nonviolence. If you don't have that renewed, those nonviolence have to be taken off. Otherwise, you are in for one heck of a lawsuit, and they will absolutely get that lawsuit because you have failed to do your part. So just remember those things about restraints. I wanted to tell you the bits and pieces about not getting, clocked in the teeth, because that's something that most people won't tell you about but should tell you about. Watch out for those guys. I would encourage you, if you can get away with not restraining somebody, don't. Most of the people don't need to be restrained. If they get rowdy and a sitter isn't helping, then there's not a whole lot you can do at that point. But don't just restrain them for the sake of restraining them. There are some nurses that will see someone as agitated and put them in restraints and say that they're nonviolent because they're trying to pull lines and tubes, and that's a lie. We're not meant to be prisoners. We're not meant to, waterboard people. And if you guys have ever been restrained, which I restrain people in nursing meetings so that they can see what it feels like, I will physically put soft limb restraints on a person while I'm at the bedside, while I'm doing like an in-service, and I'll do it for 7 to 15 minutes, and you should see the anxiety on a person's face. All right, cool. Imagine if you're a patient and you're that way for 3/4 of your day or more, right? So I don't want to hear about it. Don't put people in restraints. It's a form of imprisonment, we live in a free country. There better be a dang good excuse for putting that type of person in that type of position, right? The last person you need to restrain is someone with PTSD. The last person you need to restrain is someone with dementia. Like, what are you doing? Unless they are being physically violent and they are a physical problem and they are going to either kill yourself or kill somebody else or put somebody into serious injury, don't do it. Find another method. Try to find distraction, right? Try to find a distance sit. Try to find staffing so that someone can be there and keep them in check. Heck, do security checks every 30 minutes. They'll walk around. That's what they're there for. Just whatever you do, try not to restrain them unless you absolutely have to, because it's a big problem and it's dehumanizing and it's awful. It really, truly is awful. And if you don't believe me, then I encourage you to restrain yourself to, I don't know, a chair or whatever, and do it for 15 minutes and see how much you squirm. And then imagine what it's like to do it for a whole day. So that's my spiel on restraints, because, you know, during doing neuro ICU, I get really irritated at the level of restraints we put on people. And I usually am the one that gets a patient that's been restrained all night, and I take them right off and they're fine for the rest of the day. And then I come back the next day and they're re-restrained. And it's not the patient, it's the nurse, FYI. So stand your ground. Don't let these people be ugly to these people. Don't let these nurses be ugly. And make sure that you are following proper protocol, and make sure that you're being very careful to not do horrible things to really good people who might just be having a bad day. All right. So blood administration, all of this is accurate. Administer blood at a slower rate for the first 15 minutes is accurate. Don't go over 4 hours, also accurate. There's a lot of things in between, but reactions. So your first reaction that you're going to get from your patient is they're going to say they itch. It's always the first sign. So difficulty breathing, wheezing, this is when we already have flash pulmonary edema. We're like far, far into our blood not being taken off of us fast enough, and we're just too bad at that point. So when you get flash pulmonary edema, you're going to have to lace them in between. So they usually give you 20 to 40 of Lasix to get that fluid off of them so that they aren't overloaded. And this is usually with trauma blood. When I have a gunshot victim, I'm throwing, 6, 7, 8 units into a person because it's just bleeding out as soon as I push it in. And we can do this trauma blood pretty fast. I mean, I can drop a unit of blood in probably 10 minutes or less. So make sure that we are recognizing the second that they say they're itching, we don't give them Benadryl or tell them they're fine. We shut the blood off. We call the doc and we let them know, because that's truly the first reaction that they have. Well, what about hives? Well, the reason they get hives is because, they scratch it. And then that causes the rash. Like, think about it. If they weren't itching in the first place, they wouldn't be scratching, which would cause a nasty rash, right? So the rash or hives comes secondary. The itching is first. Then comes chest pain. Then comes change in blood pressure. Then comes disorientation. Tachypnea, dyspnea, wheezing, and difficulty breathing are a result of the flash pulmonary edema, and we should be putting Lasix in them far before any of those things happen. Matter of fact, if you're doing multiple units in a person and they keep pooping it out because they have a GI bleed, go ahead and ask your doc for Lasix. 20 should be good. 20 milligrams IV push in between units. If you hear any bubbling in those lungs, and trust me, after 3 units you will. So that's all I got for blood administration. Now, let me give you a couple of final thoughts, because I've been talking on this thing for 87 minutes and 43 seconds, but there are a couple of final thoughts. If you were looking up a section, go to your med-surg book, look up blood administration in your index. The index is in the back of the book. It literally is called the index, and it usually is in a green tab, and you flip through and you look for blood, right? And then it tells you what page it's on in your med-surg book, and then you flip over to that page and you read the section about it. The same goes for your Introduction to Clinical Pharmacology book, which is where I got information for your farm slides that I, wanted to add on to things. Your Foundations book I haven't used very much. Your Health Assessment book I've used a fair amount while I've been doing this. But these are the books that I would encourage you to have, right? Like, I don't know what the 10,000 books are that was the recommendation for you. But really all you need is a form of a medical surgical book, because honestly, these med surg books haven't changed in years. They might add COVID stuff in, but we're not even talking about COVID stuff. I mean, the information that we've had for a while. So please make sure that you are doing those things. Look in your index, figure out what page it goes to, read that page. It really narrows down your search. It really makes life easier. Don't Google your information. Google has such a change in variance. It has such a change in the degree of what it's trying to tell you. I wouldn't trust Dr. Google, right? Just like I wouldn't trust my patient to read Dr. Google and then tell me what's wrong with them, because some patients like to play doctor and tell me that this is what's wrong with them because, Dr. Google said so. Don't use that as a source. Use your medical books, please. Use your drug book. Look up the stuff. I want you to have a fair amount of knowledge about the topic. I want you to be so overwhelmed that you can't find anything new, because at that point you've learned all the material you can possibly learn. All right? Don't just get the first 2 paragraphs, throw it in the slide, and say you know enough. You don't. All right? People are going to live and die by your hands. Not the doctors, by your hands. You are going to recognize when someone is trying to get septic 12 hours before the average person does, because you know that an increase of respirations with a variant degree of 4 or more is going to be an indicator for having sepsis. All right? Well before your white blood cells accelerate, well before your blood pressure starts getting squirrely, well before your heart rate starts getting squirrely, well before that temperature spikes. That respiration is going to increase, and it gives you a 12-hour window to get that patient turned around or they die. All of this is on your hands. It is not on the doctors, because you are the one that clinically looks at them. You inspect, you assess, you palpate, you percuss, you auscultate. You do it not in that order, but you do all of those things because you are a bird's eye view to get to that doctor whenever you need something. All right. So I need for you to do those things, and I need for you to know your material, and I need for you to own it. Know it like the back of your hand. All right? Because as much as I like to play games and be funny, haha, the bottom line is it only takes one person to die on you and for it to be your fault, for you to be forever changed on who you are on the inside. And I'm here to tell you it's going to happen. People are going to die by your choices. And it's hard. It's hard to deal with that. But I need for you to remember that your job isn't to save everybody. Your job is to save as many people as you can as fast as you can. So try not to have a heavy heart with it. Have people died by my hands? Absolutely. More than I'd like to mention. But have people lived by my hands? More than I could ever imagine. Is it worth it? Some days, no. Some days it's very daunting to come home, especially during COVID, and know that your entire unit died. Do you take the blame for that? No, it's COVID. Are you going to take the blame from that? Yes, you are. Is that going to haunt you? Yeah, forever. It is. You're going to feel like everything that you thought was a good idea is going to be a terrible idea. But then you have those days where the patient should have died and they made it, and that will always stick with you. I'll never forget, I just had 2 patients die back to back. They were already, about to die. They had midline shifts, and one of them had a traumatic brain injury because, they tried to take their own life and were basically successful, but, they were still on this earth but brain dead, and they didn't make it. And it took a toll on me for a while. And I had this poor patient with a hemorrhagic stroke and a midline shift of 7 millimeters, which is nearly impossible to recover from. And I spent 4 days with this patient, and she went to an ECF to die. And I told her bye, and I cried, and I thought for 3 months I was never going to be a nurse again. And 3 months later rolled by, and all of a sudden here comes her son walking through and says, "Hi, Molly." And I heard his voice, and I snapped around, and I said, "What are you doing, person that I can't mention?" And he goes, "Have you seen Mom?" And I said, "What do you mean, have I seen Mom?" "No." Like, huh? He said, "Yeah, Mom's across the hallway. She's doing really well. She'd like to see you." All right, I'm going to get choked up here. So I walked over to the bariatric unit where she was at. She was in an overflow unit. And I walked into the room, and I knocked on the door, and she goes, "Hi, who's here?" And I said, "Hi, your son told me that you were in here. And she goes, oh, Molly. And I said, how do you know my name? Because she was basically comatose. You ready, guys? She said, I heard you sing to me every day, and I heard people calling you from outside of the room to come help on another patient, and they did it for a while. And I said, seriously? And then she proceeded to sing the song that I sang to her. Oh boy, am I looking like a fool right now on my end? Okay, so it was pretty intense. So when you have bad days where patients die left and right on you and you want to give up, remember, there's going to be this crazy little thing called this world not working the way it's supposed to work, because God is bigger than all of us, whatever your creator looks like. And you're going to realize that you're truly meant to do this. And from that moment on, 2 years into my nursing career, I never even turned around. I can't imagine doing nursing and not doing it at the bedside. I can't imagine not being at the bedside and being at, some primary care clinic, because that moment in time was enough for me to realize that this world isn't, in fact, as impossible as I believe it is. It's only improbable. So I'm talking for 9 minutes and 30 seconds because you guys are my kids and you know that. You're my children. And I want you guys to understand the value of what it is that you're doing, which is why you need to study as hard as you need to study, because things like this are going to happen to you too. And you're going to have a moment of crisis and go, what does this world truly mean, right? Because this is what nursing does to you. It puts you in a tailspin. It makes you question reality. And then you realize everything you thought was real is nothing of the sort. Okay? So, I love you. I'm proud of you all. You're going to do great. Remember how I told you to study. Remember how I told you to keep pushing. Do it. You guys are fully capable of being great. You guys are a mark on my legacy, and I am proud to have you as part of that legacy. So go do me proud, go study well, and go do a good job. I'm going to go post this to YouTube now, and let me know how the exam goes on Wednesday. All right, bye.